Hey guys, welcome back to Leagues. Today we have Dr. Gifty Kwakye joining us. She's our faculty advisor for Leagues and a clinical assistant professor for surgery here in the University of Michigan in the Division of Colorectal Surgery. She graduated from Yale University with a bachelor's degree with biology and psychology, and then she received her medical degree from Yale in 2010, and then completed her surgical residency in the Brigham and Women's Hospital, Harvard Medical School in 2017, followed by a colorectal surgery fellowship at the University of Minnesota, and she has been with us here in Michigan as faculty since 2018. Her clinical expertise is in the treatment of colon and rectal oncologic problems, inflammatory bowel disease, and anorectal disorders. And her research interests, as well as management interests, lay in the management of pelvic floor disorders, including rectal prolapse and fecal incontinence. She does a lot of work with global research and education, and we are so happy to have her here today. Dr. Kwakye, welcome to Leagues.
Thank you very much. I should have checked what level of recording is this. So it's like, do we all have to be perfectly looking? I'm sorry if I'm messing up your video completely.
No, you look just fine.
It's like I need to edit that part out. I'm sorry. I know this should be. I apologize for that, but really excited to meet you, and thank you so much for telling me a little bit about yourselves. I'm sure there's so much more to your stories, and maybe one day offline we can get a chance to like just talk one-on-one so I can hear how you got to where you are now and where you are heading, because I think it's always interesting in how we can help you achieve the next step. My hope today is maybe to share my story. It's like I tell people, it hasn't been a direct path. I have been fortunate. I have to say, actually blessed in many ways to have had opportunities I've had, but it definitely has had its ups and downs, and that's something I'm always happy to discuss again offline. But today I was asked to talk about my global surgery stuff specifically. Let me see what I can start sharing my screen with you. So hold on a second. Let's see. Sorry about that, 1 second. I have so many screens opened up right now. So okay. Can you see my screen now?
Yeah, we can see it.
Okay. And then we go to presentation mode. There you go. So I have recently, I think over the past.
We see your screen first instead of the you guys. Oh, there we go. Okay, now I see it.
Now you see it? Okay.
Yeah.
Can everybody see Surgical Educator Without Borders?
Yeah.
Okay. So about a year ago, I was forced to sort of figure out who exactly I am. Prior to that, I had thought of myself as, I'm a colorectal surgeon. I have an interest in global surgery. I have a passion for education. But then especially here at Michigan, I think there is some emphasis on trying to define a singular narrative, if that's the best way to put it, such that that is where you concentrate most of your efforts. And then you have other things that you do on the side, but there's one thing that you're mainly known for, your niche. And I struggled with trying to find that singular narrative. And what I came out after a lot of pondering was this concept of a surgical educator without borders, because it sort of like merges all my different interests and allows me the flexibility to be who I think I should be or wants to be. As Val said, I was going to talk a little bit about my journey. So I'm originally from Ghana. I was born and raised there, came to the US for college. And primarily the reason I left Ghana for the US was because I wanted to be a doctor. And at the time, a lot of my actually family, friends, teachers, a lot of people made it clear that as a female, that was not possible. Things have changed a lot in Ghana now, which is good. But at the time, it was the most I could hope for was to become a nurse. And that's not a bad thing. I think there's some people who are called to doing that. My mom's a nurse. She's an excellent nurse at that. But I just felt like I wanted to be part of making some of the decisions, um, and then being sort of like involved in the management on sort of a higher level. So I came here to the US. But when I was leaving Ghana, my whole goal was that I was going to get done with my training and go back and work there. For one thing, I felt that there was a lot of need. I had grown up um, low income. Um, and so that comes with it a lot of like experiences. I can tell you that I struggled with a lot of health issues just from what comes along with being poor. And I just felt that it was important when I was done with my training that that was where the greatest need was, and not so much here in the US. So that became sort of my ultimate goal of focus going throughout undergrad and then medical school. So I took a year off in medical school, again, because I was all about getting done with my training and going back to Ghana. I took a year off between my third and fourth year to get an MPH at Hopkins, um, because I wanted to get the skills necessary to like have the greatest impact once I got back to Ghana. If you have questions about does it make sense to take get an MPH in medical school versus residency versus when you're done, I'm happy to address that too. I can tell you my opinion has changed over time, and with a little bit more gray hair, I think I see the world a little bit more differently. But the year I took off ended up being one of the most pivotal in my life. I had a chance to, the Hopkins class was pretty huge, but there were about 20 physicians from Nigeria. These are folks who had been trained in Nigeria, had been sent to communities or rural areas to work, had applied and had come to the US to get their MPH. And then most of them were not planning on going back. They were seeing this as an opportunity to stick around here. And there was one other Ghanaian also trained there, practicing physician in Ghana, who was also looking for a way out. And I can't tell you, in my very naive, righteous anger, like very, very limited view of the world, um, I was sort of mad with them because my whole concept was that we are supposed to have our training in order to help serve the people in greatest need. And I feel like in many ways they were abandoning their post. And you can imagine how that sounds very like, again, that righteous, like snotty kind of thing, given that I had left to come in search of better opportunities. But in my mind, I could rationalize that because the whole plan was I was going to go back. But I had a chance to speak to a lot of them one-on-one and learn more about the struggles they were having at home. The difficulties, like when you go through medical school, so most of them go through medical school, don't go through necessarily a residency program. They get, depending on what your interests are, you get sent out to the villages. And it's almost like an apprenticeship model if you're lucky, but most times you are working and learning on the job. So people described their first time they had to deliver a baby without necessarily having anyone to supervise that. And then when they lost the mother and the child and how that made them feel. Or you had all that book knowledge on how you should treat XYZ, but you didn't have the equipment or the medications, and how they dealt with depression with this sense of guilt, this sense of that they were harming instead of doing what was right. And for most of them, they weren't getting paid enough to take care of themselves, their families, or their extended families. And the more I learned about them, the more I realized that it was not fair for me to judge them in that way. And a lot of them canceled me or gave me this perspective. The way they put it was I was in sort of a unique position where I spoke the language of folks here. I had gone through undergrad and medical school. I had this unique position or insight, and they felt that instead of getting done with my training and going down and being part of the mass of people who couldn't really do much because we didn't have the resources, that instead I should find ways to help, like almost like a bridge, find ways to get resources down to them, find ways to serve as an interpreter, because again, understanding what it means to be from um, a low income country, and then also having lived in a high income country. And that changed everything for me. So when I went to residency, um, and I was starting to think about what to specialize in, at some point I thought about general surgery because, again, it felt like, oh, this would be great. I could go down and do a whole ton of stuff. But then I started thinking about what is the area of greatest need, where they don't have specialists on the ground. But what is the area that I can sort of leverage my training, my expertise, and the resources in order to make a difference, and then to serve as that bridge. And of course, also life happened. I used to joke that if I had sons, I would go to Ghana immediately in a twinkle of an eye. Boys are valued, I guess, in a lot of cultural systems. That's the same thing. And again, that's the reason I was leaving. Oh, I left Ghana. But I thought if I had daughters, it would be so hard for me to take them back and put them through a system where they might not have as the same opportunities as I had come here seeking. And it ended up being I have two daughters, and so that sort of like decided that a bit for me. But that has been sort of my life journey. I am passionate about global surgery because it is many ways how I define myself. It is like I feel I would be betraying who I am, where I'm from, all the people who have invested in me to get to this point and sacrifice. But at the same time, I realize that I have a duty to my patients here, and that has driven a lot of stuff. So now this is how I see myself. I said I'm very interested in education too. It comes naturally to me. I love being around learners. I learned so much from just being around learners of any kind. I have now defined myself as this surgical educator without borders. And when I think about that, I think about it in terms of our globe, our world. I think about it on an institutional level. For instance, here at Michigan, I've been fortunate to take on assistant clerkship director role for surgery. I have other positions in the medical school. I am fortunate to be working with leagues and I'm just learning so much from you guys. But this it's been great. It's been so insightful in many ways. And then also the one-on-one interactions with people that I get to do in the operating room, just learning, teaching people skills, letting them struggle in a safe environment, building autonomy, and just enjoying that. So I'm going to take a little bit of a step back and just explain. So people tend to get this a little bit confused, and I used to. Whenever I used to think about global health or global surgery, I thought about stuff in developing countries. But the way I have come to embrace and understand global now is truly global in the sense of even like in our backyard is global. And then also when it comes to like some place across the continent is global. But I just put this here so that in case folks had questions about, getting a public health degree, do I need to focus in global health within the MPH? Or if I really want to do work in the space or do missions, is that doing global health or not? So you can see how it's sort of like interlace or intersects in many ways. And then if you have any interest in this, I included this link here, but the ACS came up with some guide for folks if you're interested in starting up or pursuing global surgery. They have this primer for it, so you could always check that out. And but feel free to share the slides so that folks can have that link. So I'm going to talk about two projects I currently am doing, and it will give you the sense or hopefully appreciation for how global has changed for me, or the way I think about global. So one of the main projects we've been doing is with the second biggest teaching hospital in Ghana. This is in Kumasi. we are trying to help them. So their ask of us was to help set up a colorectal surgery fellowship program. They have general surgeons who are performing colorectal cancer cases, benign anorectal cases, but without having specific training on how to do that. And so then that affects their outcomes. Ghana has no colorectal surgeons. They have 14 GI specialists for a population of 22 million or 25 million. And so you can imagine how that's an issue. As part of this project, helping them set up the fellowship, we decided to look at, are people getting surveillance or screening for colorectal cancer? And are providers even aware of what the screening guidelines are? So the Ministry of Health has published guidelines, which are available online and in a lot of resources. But from speaking to people on the ground, it became clear that folks didn't know about it. Most times when people see blood or bright red blood pyrectin, they think it's hemorrhoids. And in Ghana, there's a lot of local or herbal treatments for hemorrhoids. Every potion possible can get rid of your hemorrhoids, in addition to a million other things. So most people don't come for care if they have hemorrhoids, they just self-treat. Similar to other developing countries in sub-Saharan Africa, colorectal cancer is showing up in people as young as 16 years and then all the way up. But this is definitely an issue there. So the project that we are doing there, we have actually 4 different projects. We're looking at provider and community awareness of the Ministry of Health guidelines. That has been on hold a little bit due to COVID because this involves semi-structured interviews. We're doing barriers to screening, which we've done a bit of. And then we are trying to inform some of the policy and trying to make some revisions. And then also helping the colorectal surgery fellowship creation. So this is actually, we just submitted a publication. This is providers of physicians who deal either directly with patients who might be presented with bright red blood pyrectin or are involved in sort of like the subsequent care or management at this hospital in Kumasi. So we asked the physicians in their perception what they thought were the barriers to people getting screened. And you can see one of the biggest concerns was that patients were just not aware that screening guidelines existed or they needed to screen, or they didn't think of colorectal cancer as a serious health threat. And you find this to be true in a lot of developing countries. People think of things that will kill them immediately or things that are seen as being more of a danger than something that is unseen. And that is, even here in the US with our rural population, that's a big deal. Because if cancer is growing within them slowly and they can't really see it, then it makes it hard for them to give up, working on the farm, doing other things in order to go seek some sort of care. The other thing that they noticed was that, people are always worried that people scared of knowing that they have cancer, and they thought not as much compared to like just that sense of unawareness of screening guidelines. And the system level things, mainly as you'd expect for a lot of these areas, Ghana has a national health insurance scheme where people can get some things covered, but most things are a pay out of pocket system. So for instance, when we're down there, we're just down there in February, and we're talking to the one GI provider in this area. And she was explaining that if someone needed to have a colonoscopy, they had to make the trip, however far they lived, to get to this center. The patient would have to pay for their own bowel prep, and then they would have to bring their sedation medication. So if they wanted Versed and fentanyl, they would have to have brought that with them. And then if they put the patient to sleep and then during the colonoscopy, they found a polyp, but the patient had not paid upfront for the polyp, then they wouldn't resect the polyp. They would wake the patient up and tell them that they found something. And then the patient has to make a decision. Do they want to pay for that thing to be removed? If they don't have enough Versed or fentanyl left, then that's not happening. If they don't have money to pay for the polyp remove, then that's not happening either. If they agree to have a polyp removed and then they can get the Versed fentanyl in order to go back to sleep, they still have to pay for the pathologist to review it. So you look at all those levels and you can understand why people don't even show up in the first place for the scope to begin with. And so then what they're running into is that a lot of people, when they do come, have already had advanced disease. There's a risk of perforation. They can't really do much. So most of the cancers are being diagnosed at time of surgery when people are coming in with perforations because they just can't pay for all the different steps involved in screening. The other things that came up was that there weren't enough personnel to do the screening to begin with. As I said, the GI doctors are only 14 in the whole country. And then even if you think about fecal popular testing, which is what the Ministry of Health recommends, they still can't do that. So they still can't do that. Sorry about that. So that is the project that I have going on in Ghana. You can see it is definitely sort of like a great need that something is done. And this is true for most of the sub-Saharan countries. There are only a few places that have like established guidelines that are being followed. Most other places don't. There's been a lot of effort put into breast cancer because of the international attention to it, but not so much colorectal. Now, this other project, it's something that I sort of got interested in as a child growing up in Ghana. Now, there are different ethnic groups in Ghana. My ethnic group is mainly from the southern part. We do not practice female genital mutilation, but I did go to school with girls who had undergone this practice because of their ethnic group that they belonged to. And I think it was just something intriguing as a child. Like I couldn't really understand what was going on. And some of the things they talked about. In college here in the US, I took psych, I double majored in psych, mainly because I was curious as to what was driving this practice. And that I thought it was men trying to control their women, just community old traditions that needed to be gotten rid of. But that was a very insightful process, just learning about what keeps a practice that does so much harm going on, and how can we start trying to change the way people think without creating processes that keep them out or not part of the process of creating their own change, if that makes sense. So during my fellowship training in Minnesota, it was very interesting because Minnesota has a huge populations of immigrants from Somali there. And there were several women who came through who had undergone female genital mutilation, who we would do exams on, and none of the faculty I would work with would even recognize that something had been done or account for that in the treatment or the management plan that they then recommended. It's interesting because when someone has had an obstetric injury, like an episiotomy, we always ask about that. We ask about childbirth history because we know it has an impact on the way the pelvic floor works. But when we are talking to an ethnic group where a huge percentage of them have undergone female genital mutilation, and it never was something that came up at all. So this is a project that I'm doing actually with folks in Minnesota and folks here in Michigan, where we are trying to increase awareness of female genital mutilation and cutting amongst colorectal surgeons. We're trying to help providers come up with culturally sensitive ways of doing exams. And then we want to see how female genital mutilation impacts the pelvic floor function or even quality of life and people's willingness to seek care. There was one study that was done several years ago that found that if you looked at Muslim immigrants, um, a lot of them don't present for screenings such as colonoscopies or cervical exams because they are sort of invasive, and then most of the women don't feel comfortable exposing themselves. But then the percentage or the proportion of people who fail to show up is highest among Somali women. So there seems to be some added reason why they don't come for exams. So this just shows you, I remember showing this at a Grand Rounds presentation, everybody was like, ah! But this just shows you sort of like the different types of cutting. And so they can be very superficial to like pretty intense and mutilated. And that's why I guess they call it mutilation. But the type 3, you can imagine where everything is cut out and everything is sewn up. And the women basically have this tiny orifice through which they have their menstrual cycles. And if they are not reopened prior to birth or prior to their first intercourse, then this all rips up during that time. You can imagine what sort of damage it can do to their pelvic floor. So this is someone who's undergone a type 3. And then you can see this is the only orifice that is left there. So it just seems pretty weird when you are in an exam room and you see this and it never comes up because most people don't know how to bring it up. Like, what do you say? Also, when you think about it, female genital mutilation is illegal here in the US. And so you can imagine how these women feel very embarrassed or very conscious of going for any exam that involves looking at the genitalia or the pelvic floor. So this is like, if you look at the percentage of girls and women between 15 to 49 who have undergone FGM, the places in red are close to 90 to 100% of women that have undergone this procedure. These are the folks who've had pelvic floor prolapse, which is one of the things that result from that. And I just put this here. This graph was created on this Global Health Data Exchange website. It's a very easy place to go and then look for if you're interested in doing like global health research, but in the comfort of your home. It has all these data sources that are pulled from across the world. And you just have to put in like some search items and say, hey, I'm interested in constipation in this particular group of people. And you can like play around and then compare it to people in one place versus the other, and then come up with like some pretty good research papers. But this is basically what we did for this particular one. So this is the US actually. Because of the increased immigration that happened at some point, we've had a lot of women from countries, especially in Africa, who have undergone FGM here, moving here to the US. You think that this is a practice that they did at home and it doesn't happen here, but unfortunately, we've had situations a couple of years in Michigan actually, where a bunch of girls, young girls, were brought from Minnesota, and in the back offices of 2 doctors' clinics, mutilation was performed, and the 2 doctors were found and arrested. But this, you can imagine, this is part of someone's identity, then no matter what the rules are, they're going to find a way to do it. And so this is why this is important. You can see California, there's Texas, Minnesota is huge, but that is like places where there's a huge population of folks having done this. In Michigan is people from Eritrea, so basically having this done. So we are partnering with folks in Minnesota, trying to build relationships with women in the community, trying to just learn and understand how it's not a matter of pointing fingers or trying to get them necessarily to stop the practice. There are organizations that are involved in that. We're just trying to figure out as physicians, how can we better take care of them and address the issues that they're facing? So those are like such a high level overview of two projects that I'm currently doing. One which requires on the ground partnership with folks in Ghana, and the other one which is addressing um, an issue which has global significance because it is not only happening in African countries, but it applies here because we have immigrants, people who've moved here who now call the US their home, like I do, who this is part of their rituals and their practices and their processes of just being who they are. And how can we sort of take care and tailor what we do for all of these communities? So in the global surgery space or global health space, these are sort of the things that I have learned over time. Um, I think a lot of times when we go into spaces, um, I think we go thinking that we know what is best because we are coming from US institutions. We have been exposed to certain things, a lot of knowledge and resources. But I have learned that it requires a lot of humility when you go into these communities, trying to learn from them, because you realize that there's a lot that is driving some of the behavior. So, for instance, in Ghana, until I realized that people were paying for the fentanyl visit, I was like, yeah, let's create a fellowship program. Let's just get more GI physicians. Let's do more screening. But without addressing like the payment, the cost issue, or the fact that people have to travel miles and miles to get to a place. And then if they find out they have cancer, then what does that mean for them and their families and the impact on them? And maybe for a lot of them, they might be happier not knowing they have cancer. So starting a fellowship program might not really be the right thing to do. Maybe we need to focus our resources somewhere else. So just having that humility to like go and listen and learn, that's important. Also having buy-in from stakeholders early on. We are fortunate for our work in Ghana to be working with some of the general surgeons, the medical director for the teaching hospital. And that has been very crucial because otherwise, even though I am Ghanaian, I speak the language and stuff. Having been in the US for over 20 years now, I can tell you in many ways I'm an outsider because I have changed. I depend on an iPhone a lot and then all this like technology, whereas it's so different. It's very, very different there. I put on funding. So a lot of funding or grants here in the US support research that targets or seeks to help US taxpayers because that's where they get their money from. So you have to make an argument as to why what you're studying is important and relevant to US taxpayers. For FGM, for instance, this is important because if we have a huge population or a relatively huge population of folks who are not coming for screening because they are worried about being judged or they are worried their doctor is not going to do a really sensitive exam, then what will happen is that they are going to show up later and then be at a higher cost to the society. And so finding them early and doing something to intervene early ultimately is helpful. IRB is a pain in the behind. We've spent like almost a year and a half trying to get IRB approval in Minnesota to talk, to do surveys and semi-structured interviews of the women there. A lot of that has to do with understanding vulnerable patient population that we're dealing with, but it is very painful. Our IRB in Ghana too was like a very lengthy process. And so there's just a lot of hoops, which sometimes can make it frustrating and it's easier sometimes to think about giving up. And then I put here, it usually does take a village. I can tell you my family has been very supportive of this. So I sort of split my time, mostly because of COVID now I'm here. But a lot of the work I do involves being in multiple places at the same time. But sometimes you just need the right sponsor. And I hope through leagues, you get an opportunity to learn what's the difference between a mentor, a sponsor, an advisor, I mean, there are all these levels to it. And it's important to know the difference because you're going to need each kind of person in your corner for when you want to get to the next level. And then I have found that, again, I put here mentoring, but just being able to learn from anyone is like, I see it as a gift. And so in this global surgery space, I am learning from a lot of folks who have walked the path before me. I'm learning from folks who are on this journey with me right now. And I'm also learning from folks like you who are coming now starting out and who are asking the tough questions to make sure that we're doing things the right way. So I will end there and I will stop sharing my screen. And what I'm going to do is I'm going to open it up for questions because I did went over a lot of stuff. But just to summarize, I talked about my journey and then I just went over 2 projects just to give you a sense of how global research can sort of like, you could do it from home actually, and it's completely fine, or you could travel and go somewhere else.
Thank you for that talk, Dr. Kwakye. Any questions, guys?
I have a question. Hey, Dr. Kwakye, thanks for the talk. I was wondering if you could tell us a little bit about, your MPH and telling us, a little bit about that, and then also, what are your thoughts on like, is it possible to learn these skills without getting an MPH just through like experience and through mentorship, or do you think you actually need an MPH to do these projects? Yeah.
Again, Val, is this everything's being recorded, right? I was going to say something like this, my husband on this, but we'll save that.
So we will do, we'll probably do like 10 minutes of the recorded questions, and then we'll come off recording, and then we'll have another 10 minutes for off the record questions.
Okay.
And answers.
I have totally dissed him multiple times in public forums, so he's out there. He'll be like, but the reason why I bring him up is because I think that's like a very important question. When I took my year off from between my 3rd and 4th year, so at Yale, I can tell, I think my year group, close to 70% of people took a year off. Yale has we say no grades. We don't take, we take exams, but no one tracks it, it doesn't go on our transcript. And I think certain years there's this need to prove yourself one way or the other by having something else on your CV to make you stand out. So a lot of people take a 5th year. And most people do research, like hardcore research, get some stuff. Very few people get an MPH. And at the time, very few people got an MPH in surgery who were going into surgery because there wasn't that understanding of global surgery or the need for that. I took a year off because, to be quite honest, I was getting very jaded. I had gone into medicine being in love with the idea of helping others, making a difference. And it just seems very cliche, but I really felt like this was a calling. And that's why we were supposed to be there. And just seeing our healthcare system and how people were being treated. I went to Yale is in New Haven. So when you think about the dynamics, I think that just broke me. And I needed to sort of take some time, step away, because I wasn't sure that medicine was necessarily, if this was what it was about, especially when it came to the disparities, then I wasn't sure I wanted to be in that space. So when I took a 5th year, it was trying to find that time to reflect. My husband now, who was in the friend zone then, felt that it was a very expensive use of like a 5th year. That's why I was like, is this being recorded? But he was in the friend zone. So I was like, it was a very expensive use of a 5th year. And he's an actuary. Well, now he switched, but he was like, cost effectiveness. That word got drilled into me so much. So is this cost effective? Do you need to spend how much thousands of dollars to figure out if you want to do this or not? And the only way, I wouldn't say he gave me permission, but the only way he could rationalize it was because I got a scholarship to go to get my MPH. And so in that way, it was like, okay, it's cost effective. It doesn't make any difference. It's like 1 year of your life. You could do whatever you want to do with it. At the time, I thought, I was making this transition. I was going to do the MPH thing. And that was where I was going to connect again with that sense of, I want to care for people. The MPH, public health, was going to be like, this was what I was always seeking. And somehow I got stuck in medicine. And this was where I really bought into the saving millions of people at a time instead of this one-on-one interaction thing. Now I look back and I realize that in my medical school year, I had no idea what I really wanted to do with an MPH. My classes were so haphazard. It was like someone's like, oh, this is an interesting class. I'm like, sure, I'll take it. It's like some cute guy. Oh yeah, I'm gonna take that class too. It was just like all over the place. And if you ask me, what did I really walk away with in terms of skills? There was some stuff. We were required to take 1 year of statistics, so that I got. But in terms of really crafting a skill set that I could use for the next level, I think because I was a little bit lost myself in terms of what I wanted to do, I just couldn't come up with a good plan. I contrast that with some of my co-residents. So I went to the Brigham, and a lot of people they have a 2-year required research time. Some people get an MPH during that time. And it was so different to see how people utilize their MPH then. Because I think folks are like, I'm working on this project, or I see myself doing this. I need XYZ skill set. I am going to take the database I'm working right now in lab, and I'm going to take that to my MPH class and then use that to analyze during the time. So I'm not using all these like dummy data sets and stuff. Several folks went into global surgery. They have a global surgery fellowship. So some folks did 1 year MPH and then went to Rwanda or Haiti to do another year there. And they were so productive. Like they are there working with the Ministry of Health, creating all these policy changes. And I was like, yeah, I sort of like missed the opportunity because I just didn't use my MPH right, the year right. Now I'm like, if I have a medical student who comes to see me and it's like they want a year off to get an MPH, we really have to have a heart-to-heart talk. And you have to tell me like, what exactly? Is it cost effective? I hated it when he used to say that, but is this cost effective? And what are you really, really trying to look for? And you have to show me your plan. Like, what is the plan? What classes are you taking? What do you really need this for? You don't need an MPH to do global work at all. I think having a medical degree, a lot of people here are in global but don't have MPH. I think sometimes it can signal that, hey, you have this expertise. But I find myself in situations where people assume I know more than I really do because it was like, how many years ago? So you don't need it.
Thank you so much for the answer.
I will echo a lot of the things that Dr. Kwakye said, just because I'm like right now I'm not getting an MPH, but I'm in the middle of like an advanced degree. And when I was in medical school, I considered like I was saying similar reasons. Like I was like, I just like need to book it for like just 1 minute and like stop drinking from the water hose. And like this seems like it will apply to this like loose idea of what I want to do. And like, it's like that's an extra degree. And actually my mom and your husband, she was like, Valeria, are you really going to do this? Because it is like another full year of $40,000 worth of loans. So at the end, and she's like, you're going to go over your like max of loans. So I did not get a scholarship, and it was a blessing because I was able to finish. But now taking coursework that is my master is not quite an MPH, but a lot of the coursework is related. Actually, my partner is doing an MPH at the same time. So we get to compare like the coursework that I'm doing with the courses that he's doing that kind of caters to like a broader audience versus like this coursework that I'm taking right now as part of my fellowship, and that is also accessible to a lot of residents that come and do it, which is with this focus. And you start thinking differently after you have been taking care of patients for reals. Not, I mean, like as a medical student, you're a key part of a team, but like once you have been in it for like 80 hours a week for like a couple of years, and now you have seen, like you have identified the problems that the questions that you really want to answer, because they're going to change the way how you're going to take care of patients. It changes the way how you see coursework, and it's hard to explain. But like now when I sit down and like I broke my, this is a funny story, you don't know Dr. Kwakye, but last week I broke my computer trying to download Stata into like my tiny little map. Yeah, I broke it. But like I needed to get it. Like my whole thing, I was like, oh, like if this had been like an undergraduate class, I'll probably have to like figure out what the bare minimum was to like pass the course and move on. But I'm like, oh no, I actually like I need to learn this, because like the questions that I want to answer and like the data set that like keeps the answers to those questions is something that I need to learn how to do. And every time that someone comes and gives a lecture about like X or Y topic, they're all topics that I'm like using and applying toward my research projects. And that overlap of your coursework and your research as a research resident is actually huge, because you don't want to be doing double work. A lot of the thing that comes with being able to be like both like productive in the lab or just productive period as a faculty member, like just being able to overlap a lot of your like clinical interests with your research life, so that you're not doing 17,000 things at the same time, comes with some of that overlap. And so like right now I'm like, oh, for like my first project of my master's, I'm going to take this first data set that I already had identified, and that's going to be what my master's project, and it's going to be this. On my first literature review, I'm actually like reviewing literature that I Jessica and I are writing a paper on. And so it turns out to be that you're like minimizing the amount of work. And sometimes when you're in the middle of medical school and just like in the little hamster wheel of trying to get through, it's a little harder to make sense of a lot of that coursework. Not that it doesn't apply. A lot of people don't go to residency after medical school, and sometimes that additional training like does set them up for whatever the plan is. But I will tell you, if you knock out on my door, I will be doing the same thing as Dr. Kwakye said. I'm like, show me the plan. And like, why do you need to take the stats class? Because that boy is actually not that cute. So like, you should probably not take it. So those are just my 2 cents about the extra degree while you're in med school.
Yep, wasn't that cute?
It's a cost effective. Any other questions, guys, before we start recording?
Dr. Kwakye, I was wondering if you could talk a little bit about, so being in the residency application frame of mind, how would you recommend that a student who's interested in global surgery, like inform themselves about which programs like truly are prioritizing this type of work and would be supportive of using the academic development time to work on something like this that maybe in some places would be considered non-traditional?
That's an excellent question, Garcia. So when I was applying, there were only 4 residency programs in the entire country that were doing global surgery or had anything global public health related. And the way I found out about it was online. The folks who are in that space are really proud about it, and they've got a lot of stuff online. Folks who are not so much, you can see it's like a one-liner and there are a whole list of different things that they're doing. I can tell you that now more and more residency programs advertise it because they know a lot of applicants are interested in the space. Now, the ones which are really, really serious about it are the ones that are going to have some sort of dedicated faculty to it, so a faculty who oversees it. They might have a center for surgery and public health or a center for global surgery. A few might have put on their websites mission trips. So a few will highlight some of their faculty who go on trips and sometimes take residents with them. But those ones I'll say be cautious about, because those are usually being driven by the faculty and not necessarily the institution. So you want the ones which have an institution-backed thing, where they would say, our residents the ones that are really good, I would say our PGY3s, half of the class has an opportunity to go rotate in this particular place. Or they would say, we have a partnership with this community hospital, this hospital in this particular country. The other thing to do is to ask the residents. Hopefully, a lot of the programs are providing opportunities for you to talk with the residents virtually. And you could ask them, like, if you wanted to go abroad or you wanted to do this global research, is there an opportunity to do that? Has anyone in your program done that before? Is it an every year thing? I can offline, Gracia, we can talk about, there's some places that are doing amazing work around this. There's one institution where their entire PGY3 class gets to go to an international site. And it's not only for clinical, but for paired research, where they pair up the resident, the American resident, with a resident down in the other country, and then they do research where you are the experts guiding and helping the other learn some research methodology. And that's amazing. And if you decide you don't want to go, then you go do a community surgery rotation, so that at least you're learning how to work with underserved populations here in the US. So we can talk offline, and I can give you a list of folks to do that. But a lot of them will put it on their websites.
Love that. Thank you.
Any other questions? Okay, I'm gonna stop recording. Oh, there you go.
I wanted to know, do you happen to know if there's anything being done or any policies being worked on over in Ghana to address what you mentioned about the colorectal cancer operations?
So if I heard you right, Gabrielle, am I pronouncing that right? I hope so. You are asking if there's been any policies that have been made to sort of try and address the colorectal cancer screening thing. So the Ministry of Health has their guidelines. So they said, based on the cost effectiveness and stuff, but a lot of screening revolves around that. Do you go with the screening technique that has the highest success rate of like detecting cancer, but it's more costly? But do you go with the cheaper one where you might miss some of the cancers or polyps, but it is less costly? And so they've decided to do fecal occult blood testing nationally, and that if someone tests positive, then the next test would be a colonoscopy. So that is the guideline. But as you realize, there's a difference between having a guideline, so a protocol and something, and then the implementation or the carry through of it on the ground. So that is where the problem is. And since a lot of folks can't come to health centers to get these tests done, they haven't really seen an uptake of it. Like at this big teaching hospital, we asked folks, and part of this study that we did was, if you have an asymptomatic 50-year-old gentleman coming in with bleeding, what would be the first test that you would recommend? And the answers were like all over the place. And these are from physicians, practicing physicians. You can imagine when you go into the community, no one is going to know anything about this. And so I think there's a lack of education across the board, even amongst the medical providers. And then, so nothing really, the guidelines are there, and I'm sure for the Ministry of Health, there's a checkbox, but everything else is going to need money and then a champion. Right now, the effort is in breast cancer. So the National Health Insurance will pay for your chemotherapy for breast cancer, because it's just the power of when people get together globally and the things that they can do. And breast cancer is a perfect example of that. Colorectal cancer, unfortunately, hasn't had that sort of energy around it.
Thank you.